If you don't hear that, you're not being recorded. I think you can actually ask me to record as well. And I think I have to give you permission, but I think you can ask me if you want to record this yourself, you can ask. So where are we? What I'm going to do is I'm going to share this the case with you as well, so you're not going to miss too much here. Okay, so all right, there's your tests. So basically, you take their arm down there, so they're essentially, you can't see me anyway, can you? So they abduct it, flex the elbow, laterally rotate it, puts a bit more stress through it. Then you palpate the radial pulse while they bring their head over and away, and that position there. And you're looking for that pulse to disappear. If you're really fussy about this, you can use a stethoscope and listen to it. It's sensitive for vascular problems, but again, it's got its diagnostic issues, because with all of these tests, actually, all of this, particularly the vascular tests that are not symptomatic with losing a pulse, they're very common in an asymptomatic population to be positive as well. So you really don't know what you're doing, except if, this is what drives me crazy about the way they look at these things. If you do one of these tests and they lose the pulse, they've also got all of the symptoms of thoracic outlet syndrome, and the symptoms are worse when they lose the pulse. How much more evidence do you want? Why do you care about the asymptomatic population? You're dealing with symptomatic people. So that's Adson's. Ruse tests. So basically up in the air like that. Can you see me? And they're doing this opening and closing. Now they're supposed to do this for 3 minutes or until they get symptoms, which is a bit of a push. I mean, a lot of these people can't even do that for a minute without the arm getting heavy and weak. But again, you can take the pulses, but this one is more sensitive for symptoms. And it's very sensitive. Again, you're not dealing with the general population, so it makes a difference. In the general population, it may be iffy. So there's your Ruse test. You've got sensitivity and specificity down in the bottom corner. 84% sensitive, specificity is low. So it probably isn't the best test to make a diagnosis of when it's positive, but it's not bad for when it's negative. When it's negative, the chances are they don't have thoracic outlet. It's simply because of the high sensitivity. Actually, if you look at this, there are a whole bunch. If you put in thoracic outlet on Google, you'll see half a dozen or more tests, and most of them are just slight variations on those three. But there are loads of them. Everybody wants to get their name on this for some reason. So, all right, let's look at a thoracic problem. You've got a 60-year-old man complaining of pain running around the chest, right side of the chest, all the way to the sternum at about the level of T7. Okay. There are your possibilities. So I've laid out the hypotheses for you. So pick one. You in, Canal? Canal? We lost you, did we? Still losing you. All right, have you all picked a hypothesis?
You're too hard.
Oh, it's not too hard. I've got a man 60 years old with pain running around the chest. You've never seen that in your clinic? It's too hard. Now, remember why we're doing this. This is to determine whether you're going to manipulate this man or not. 53-year-old man.
Number 3.
You're number 3. You want a rib dysfunction. Okay,
Yeah.
then think about how you're going to prove it. All right, Thomas?
Yes.
Okay. Who else? Nikita, what do you think?
Segmental dysfunction.
Segmental dysfunction, okay. Again, think about proving it now. Thoracic.
I'm stuck. I couldn't make a decision so far, but I'm more.
I think I'll go with segmental dysfunction as well.
Segmental dysfunction, okay. Natalie?
I'm not sure what TX syndrome is.
Oh, Tietze syndrome is actually, it's costochondritis. The difference between it and costochondritis is supposedly that Tietze syndrome has swelling and costochondritis doesn't. Okay, so given that, probably Tietze syndrome is a more severe case of costochondritis because they have no idea what Tietze syndrome is other than inflamed costochondral junction. So it's probably just a more severe costochondritis. Okay. Ambika, I know you're there.
I'll try the first one.
Disc herniation with T7 radiculopathy. All right, now let's have a look, see how we're going to prove this. Let's take the disc herniation first. Now I'll give you a piece of information on disc herniations. They are extremely, extremely rare. All right, that doesn't mean to say you haven't got one in your clinic, but they're very, very rare. So what we need is an illness script, an essential illness script for a disc herniation with a radiculopathy. So what is it?
Sorry, we need a what for a radiculopathy?
Well, you need to be able to prove it. So
could you
come back to the essential illness scripts again. But disc herniation, what are the characteristics of it? The diagnostic characteristics of it?
the positional changes? If let's say flexion is aggravating the symptoms more and extension is relieving it.
Okay, let's stop right there. This goes back to a disc herniation in the lumbar spine, yeah?
Mm-hmm.
And this is Mackenzie more than anybody else, and that's not how a disc works. A disc is like a lumbar disc, they can't walk. They don't get better when they walk, they don't get better when they bend backwards. Flexion and extension are both severely, severely limited and very painful. The Mackenzie view of disc herniations is just plain wrong. And if you talk to any neurosurgeon or orthopedic surgeon who deals with disc herniations, they will laugh at you if you say that. It's not the way disc herniations work. And the Mackenzie Institute really should stop saying that now Mackenzie's dead. They just look like idiots. So no, it doesn't work that way. These things are really bad in both flexion and extension. And it is severe, severe pain. These will not get better with push-ups. A disc herniation is either really severely painful or it's not painful at all. So you've got a large percentage of the population walking around without any symptoms at all of a disc herniation, but it shows up on MRI as a disc herniation.
All right. Okay.
Okay. So let's have a look at the radiculopathy. What sort of pain would we be looking at if this was a radiculopathy? If this was radicular pain?
Like a burning pain?
It can be. A neuropathic pain can be burning, coursealgic pain. But when you get compression of the spinal root or spinal nerve, It actually is more usually an electric shock pain, lancinating. So it zings down the limb or around the chest. Now, the thing is, though, I can have a radiculopathy without having radicular pain. Is that okay? If it's a simple compression of the nerve root, and there's no damage done to the nerve, you will not get neuropathic pain with it. The nerve needs to be damaged for that to occur. So, and the same with coursalgia. So, but I can have referred somatic pain, which is probably coming from the dura. So the dural sleeve gets compressed, and that's painful, and it will give you somatic pain, which isn't, because the dura isn't a nerve tissue, you don't get nerve pain. Is that okay? Yeah?
Yes.
So the question is, if they've got somatic pain, how do you know whether they have a radiculopathy or not? This is general now. Anybody?
If it's a radiculopathy, there's not gonna be localized pain in that area. For instance, now if this is this chest pain, if you touch the chest, then there won't be tender spots, or on palpation there won't be some tender spots in the chest. Then you start to think that pain must be coming from somewhere else.
Well, not necessarily. I can have a radiculopathy caused by a neuroma on the nerve, and that may well not be tender. So we're not arguing whether there's a disc herniation here at the moment. We've already sort of dealt with that. You're looking for severe pain that's got to limit both flexion and extension. Yeah, we're now talking about the radiculopathy. So what's the operational definition of a radiculopathy? What makes it a radiculopathy? What clinical signs or symptoms?
Would type of pain be helpful to us to differentiate between somatic and radicular pain?
Somatic pain, all right, let's do neuropathic pain. You can include, if you want to, given the International Pain Society standards, you can include paresthesia as a radicular pain if you really want to, but not many do. But paresthesia is certainly one of the symptoms. But neuropathic pain is lancinating, an electric shock that is on and off, just like that. As the nerve gets stressed, it's on and off. And that's usually from nerve root, spinal nerve, usually. Coursalgia, hot, dry, burning, itchy pain is more constant. You get that sort of thing with diabetes, central nervous system problems, and peripheral neuropathies from non-diabetics. So the somatic pain is anything that isn't that. All right. So these are sharp pains, stabbing pains, shooting pains, achy pains. It's everything that isn't one of those three things. Objectively, though, with a radiculopathy, you can make a diagnosis of a radiculopathy based on neuropathic pain. You can't quite make it on paresthesia, though, because there are other... But otherwise, objectively, neuropathic pain is sensory loss, motor loss, reflex loss. All right? Any one of those in a radicular distribution. So the problem you've got in the thorax is trying to test for sensation. It's almost impossible. There's so much overlap going down. Even though the muscles and everything else are more segmental than anywhere else in the body, sensorially, there's so much overlap there, it's almost impossible to test specifically for anything. Reflexes, which reflexes are you going to test? T7. What do you think?
Abdominal reflexes.
Yeah, I mean, it does, doesn't it? T7 does the high abdominals. So yeah, you could try reflex tests and scratch tests. You could try Beavers tests. Familiar? Beavers tests is you have the patient lay down and they lift their head up and you watch the umbilicus. It has to be done really quickly, but you watch the umbilicus and it will get drawn to one of the quadrants. I'm going to draw for you. Hang on a minute. Am I? That's a question. Am I going to draw for you? I'm loath to do this because you laughed at my previous attempt at drawing. Okay, so where am I? Sorry. There you go. There's somebody's belly. There. You visually define it as 4 quadrants with the umbilicus sitting there. So everything up there is T7 to T7, 8, 9, T9, I think it is. And down here, yeah, T10 to 12, T7 to 9. So if I've got weakness in this area and everything else is strong, when I get them, the hell's that gone? Oh, it's vanished on me. Actually, is that's I can do it here, I think. There, 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 there. So if we got weakness up in here at T7, this will pull, that will pull, this will pull, and that will be weak. So you'll see the umbilicus pulled down to that quadrant. But it's got to be really quick. Unless there is really gross weakness, everything will balance out, and this one will kick in and it will balance out, so you won't see it. But you've got to watch for that very quickly. The other thing is the scratch reflex. You just come in and scratch. You scratch with a reflex hammer tip, and you're looking for a normal reflex. Mostly that's best with central nervous system problems. The other thing you can do, which nobody seems to think about doing, is to palpate. Is to palpate in the rib, between the ribs at that level, and get them take a deep breath in and out and feel that if you can push in. All right, if one side gives way easier than the other side, then you've probably got a myotomal weakness. And the myotomes are fairly well divided out. They're actually quite specific to that segment. Whereas sensation isn't. So you can test for it. But what I'm going to say to you is, if I can get back to where it was, none of that is positive. So given that we've got no sensory loss, although we can't test sensory loss, we've got no weakness, we've got no neurological symptoms, and I'm going to go one stage further and say that movements are actually pretty good. We can probably eliminate a disc herniation, yeah? Who wanted segmental dysfunction?
First of all, I'll try to ask about the range of motion to see the mobility at the level of that spine.
Okay, fair enough. The problem you got is, oh, you need another test. It's not enough, is it? Unless it's unlimited, unless the range of motion is full range, even that's iffy. But unless the range of motion is full range, you can't be sure. You need another test.
I would also like to Okay. Oh, sorry. Go ahead, please.
No, go ahead. That's okay. Go.
Take palpation along the spine to see.
Yeah, that's what I was about to say.
You can do PAs, yeah. I mean, if the PAs are negative, then the chances are they don't have a segmental dysfunction.
Mm.
Yeah. So we do those two tests. It's this is an atypical segmental dysfunction if it is, because of the amount of referral. Generally speaking, the amount of referral isn't that much for segmental dysfunction. And it would argue that the amount of pain given that referral is probably quite high. So that's another question for you. How bad is the pain?
Mm-hmm.
Yeah. In this case, the pain, no, I'm not going to say that. So if the pain is too high, the PA is too severely positive, when you're getting referral plus spasm, for example, and a lot of pain with your PA, this probably isn't a typical, very typical segmental dysfunction. It's very atypical, or it's something else going on there. And you're better off assuming something else is and try to investigate that. Yeah. Costovertebral or costotransverse biomechanical dysfunction. Same thing, it's a segmental dysfunction, basically. Strictly speaking, well, it is a segmental dysfunction, but it's the same thing. It's got the same diagnostic features, moderate pain, moderate referral, and so on. So this pain's going all the way around, so it's probably not that. Costochondral dysfunction. Or costochondral dysfunction. Costochondral dysfunction could disable the rib at the costotransverse or costochondral junctions, costotransverse junctions rather. So that would be a cause. It could be a cause for the rib dysfunction at the back, but the costochondral junction is going to be painful at the front if this is a painful problem. Yeah. So while it may cause a dysfunction posteriorly, if it's actually painful itself, it's going to be painful anteriorly. And it probably won't refer very much. There's not likely to be that. Same with costochondritis, same with tetes. Now, on all of those, chondritis, chondral dysfunction, tetes syndrome, palpate. If it's not tender, it probably isn't. Okay. Shingles.
Shingles always comes with a rash.
No, it doesn't. It doesn't.
Really?
No, the rash comes on up to 96 hours after the onset of pain. So if you've got a patient who's walked into your clinic and says, I've got this pain today, then they probably won't have a rash.
Okay. What about the location of pain? Your lateral?
Shingles pain can go all the way around.
Okay.
It's actually a peripheral neuropathy, isn't it?
Yes, that's correct.
For shingles, wouldn't you ask about vision loss or any issues with eyesight as well?
No, it's not that nerve that's being affected. The thoracic spine is actually a very common area for shingles to make itself felt. You can get shingles on cranial nerve stuff. Ramsay-Hunt syndrome is one of them that does the vestibular and the, I think it's the acoustic nerve, I think. But it may only affect one nerve, shingles. And the thorax is a very common spot for it. So they may have no other symptoms. And it's also worth remembering these systemic disorders, while we talk about them being bilateral, they are eventually bilateral, but they don't always start off that way. They can start off unilaterally, go to bilateral, and go unilateral, then unilateral to the other side, then bilateral, and so on. So they don't always show up as bilateral. In fact, the easy stuff shows up just the way the textbooks say. And you won't have a problem with them because it won't get to you if it's going through a doctor. It's the atypical presentations of medical conditions you want to concentrate on. Because they're the ones that's going to walk into your clinic under their own steam, or the doctor's missed it and has referred them to you. But it's not going to show up as a typical textbook case. I think we talked about that with cancer last time, didn't we? Or the time before. You got this script in your head where it's unrelenting pain, pain at night, night sweats, weight loss, nausea, vomiting, all the rest of it. That's true. It's right before they die. That has to get there. Yeah. And that's when you'll see them, not when they're on the verge of being admitted into an emergency room or palliative care. It's the stuff that's walking into your clinics that don't look like what it is. Shingles is a neuropathy, so you're looking for neurological symptoms. So a combination of neuropathic pain, which is usually causalgia with shingles. The range of motion may be full range, but it's likely to be painful because as you stretch a nerve with one or more of one of these movements, it can send off a lancinating shock down through the nerve. But you've got neurological signs and symptoms, good range of motion to you. It's not a disc that's causing it. And he's a good age for it. 63 is pretty good. It's not your area though, is what it comes down to. You've got an unidentified neurological condition. And given that we're talking about manipulation, you're definitely not going to manipulate this. Okay. Diabetes doesn't usually affect you, but it can. And again, it's a peripheral neuropathy and it'll show up just as shingles does. Psychiatric cases. You're not comfortable. If you're not comfortable with a patient, you shouldn't be treating them. Because if it's not psychiatric, it's psychological. And if you're having, or it's personal, but if you're not comfortable treating a patient, the chances are this is not going to end well for anybody. Yeah. So you're better off swapping it with somebody who doesn't know as much as you do, or firing it back to the physician. Tumors are difficult. Early stage tumors look just like a musculoskeletal problem, but in this case, if this is a neurological patient, then it's going to be somewhere on the nerve. It's probably going to be an extradural tumor, and they can show up like almost anything, but it's going to show up probably neurologically, but not centrally because it's extradural. So you won't see stuff going down the legs. But again, it's quite uncommon. Is that okay? Given if they had pain running around the chest and it was neuropathic, they're 63 years old, they had good range of motion, I would be thinking shingles on that. If they had severe pain, failure to move in any direction, I would be thinking of disc herniation with a radiculopathy. If they had good movements, moderate pain, moderate referral, I'd be thinking segmental dysfunction, which includes the rib problems. And if they had pain in the anterior chest, I'd be thinking of costochondral pain. Is that okay? Got any questions there? You good? You can all read that. There you go. Just move you out of the way. Okay. All right, this is a patient I had years and years ago in the clinic. She was about 68 years old, from what I can remember. She had moderate to severe somatic pains. This was aching and shooting pains, but not neuropathic. Right side at about T6, so this pain's zigging around here, and it was going out about 10, 12 centimeters from the spine, so it wasn't going all the way around. The pain had been present on and off for about 2 weeks. She had no idea what caused it. And when she gets it, there's no triggering instance. There's nothing consistent as to why the pain comes on. Sometimes it's there on walking, other times on prolonged sitting or activity, becoming more frequent, but not more intense. And she gets pain periods where there is no pain there at all. You've got full range of motion and no pain. So, any thoughts on that?
My first thought is osteoporosis.
Now, osteoporosis isn't painful until it fractures.
Yeah, okay.
Then it's painful. So if she had fractured this, And this is actually what happens when you start looking at predispositions, ages and so on, is you start like clinging to one thing. So she's 68 years old. She may well have osteoporosis. Very good chance she does. But if she had fractured this pain wouldn't be on and off. She would know exactly what hurt her and it wouldn't go away. Yeah. So if you forget that bit and you just look at the presentation, the first question is, does it make any sense to you? Anything? Nothing? If it doesn't, say so, it's all right.
It seems to be all over the place and so many things going on.
Yeah.
And,
It's confusing. Is anybody not confused by this?
No.
All right, so I was confused by it as well. But I did a biomechanical exam on her and she had a segmental dysfunction there. Okay. Also, PA's over that level. It's about T6, 7, somewhere in there. PA's over that level were positive as well. She didn't have osteoporosis as it happened. A doctor had done a bone scan on it, make sure of that. And I manipulated her and she felt better. A couple of hours, saw her again a couple of days later. She came back in and said, it was good for a couple of hours, not bad anyway. It helped. But anyway, I did that twice and it still wasn't changing it. And I fired it back to the doctor and she had a tumor. Benign. It was about the size of a banana, a small banana. It was extradural. And they took it out. So why was it on and off? Who the hell knows? Unless it was swelling and then shrinking again. Otherwise, I don't know. But the thing here is it makes no sense. I should not have manipulated her. I should have said to myself, this doesn't make any sense. Plus the fact, if this had been a bit lower, if this had been around about T8 or lower, I wouldn't have messed with her at all because tumors in that area from about T8 down to L1-2, pain in that area is about as often caused in this age group by tumors as it is by anything else, if they've got no history of anything else. A little bit higher is a bit unusual though. But yeah, I didn't do the right thing there. Should never been manipulated. I don't think, well, I couldn't make a diagnosis from it, except I have no idea what the hell it is. And the more you do that, the safer you'll be. Instead of assuming that it's got to be this because this is common and this is not common, like you do it on the presentation of the patient. You don't worry about looking at predispositions. Like it's a 68-year-old female, so I wouldn't make it, if it's been lower down, I wouldn't make a diagnosis of prostate cancer. Yeah, so the gender plays a role and so does the age. But it only plays a role. Once you've made the diagnosis, then you apply all of the other information to the diagnosis. And you either accept the diagnosis or you refute it. But if you add in everything else, then you run into trouble. This is interesting. I'm just doing a presentation on this. This is Goldman's algorithm. It's really quite interesting. It's nothing to do with us. Okay, so this was on cardiac patients, patients with chest pain being admitted to Cook County Hospital. That's where ER was set. Yeah, remember the TV show? This is where it was set. And what they did was the guy who came up with this, Goldman, went through all patient records for the last God knows how long. And they did a mathematical analysis of it, and they found there were 4 things that each of these had in common for a cardiac problem. And if I haven't got them written down, I can't remember what they are. But it was chest pain. I can't remember offhand. But it was 4 things. And what they found was when they started to use these, they made the physicians use them. All right. So it was a research project. So they gave half the physicians this algorithm, and half they said, go and look at the patients in your own way, come back with a diagnosis. And they found that there was about 95% accuracy in the diagnosis from the algorithm and about 75 to 85% when it's left with a physician. Now, this was about saving money as well. So they only did tests when they used the algorithms, the appropriate tests. What the doctors were doing when they were looking at it without the algorithm, they were throwing every bloody test at it they could think of. But in this case, they simply used the tests for cardiac problems rather than everything they wanted. So it saved money and it was more accurate. And he did. He ignored everything else. He ignored predisposing factors, family histories, age, everything, and just concentrated on the factors that were there on presentation. And he said, don't get upset by this, because the doctors were getting upset. He said, this frees you up now to look at the complicated stuff. Not making the diagnosis is not complicated. What's complicated is determining what caused it and how you're going to treat it. So it frees you up to do that. But when the study was done, the buggers went right back to doing what they had done previously. So even when you've got good research like this, it doesn't get used. Let me ask you this. Are you doing stress tests for the craniovertebral joints? There's a transverse shear one where you lift C1 up with the head and see if you produce symptoms down the legs. Yeah, that's probably the favorite one. And then there's a sharp purser test. Have you come across sharp purser? No?
Is it the one used to test instability, ligamental problems and stuff like that?
Well, it's not really for the ligament. It's for stability. They're all for stability. Yeah. And there are contraindications to it, and I'll talk to it in a minute. But basically what you do is you semi-flex the neck, making sure that the AO joints flex, and then you stabilize C2 spinous process with your thumb or with a key grip so it's solid, and then you push the forehead backwards. You don't extend it, it's a straight push back. And what happens is this: if you've got an instability, yeah, it's better. If you've got an instability, this is the way it should work. So the axis is there, the atlas anterior rib is there. So when you flex and extend, that happens. So there's no migration of the atlas. So when there is an instability, this drifts forward. So by flexing the head, you do that with it, and then you push C2 forwards, and that happens. Okay. Now it's been misinterpreted, and it's been tested, and 4 millimeters of drift. It has a positive likelihood ratio of 22. So I think the sensitivity is about 84 and the specificity is about 96. So this is a really good test at 4 millimeters. Not so good at 3, but at 4 is really good. What a lot of people misinterpret this test is as you push back, so it's in that position. So when you push the forehead back, that happens there. And you take the pressure off of the spinal cord, so the symptoms go away. Yeah. The problem with that is you need about 8 millimeters of migration in a normally sized canal to get symptoms. So this is very, very insensitive compared to sharp purser. Okay. Do they use it? No. People won't use it for a number of reasons. It's a provocation test. So having to put their head forward that way is dangerous. On the other hand, lifting C1 up isn't. Now, if somebody could explain this to me, I'd love to know. But even with the test, and everybody purports to do evidence-based practice, even with solid evidence like this, they still don't do it. One of the arguments being that the people who were tested had rheumatoid arthritis or ankylosing spondylitis. So this only works with ankylosing spondylitis and rheumatoid arthritis patients. But that's stupid, isn't it? It's either unstable or it's not unstable. Doesn't matter what caused the instability. It's stable or it's not stable. It works or it don't work. So even when you've got good research things, Goldman's paradox is a case in point, clinicians won't use them. In Goldman's case, because they think they've wasted their training, which they haven't. In this case, I have no idea why they don't want to use it. If somebody could help me out with that, I'd love to know. But it makes no sense. Okay. Tell me I'm recording this. I am still recording. Okay. Thorax, as far as manipulation is concerned, is, I'm going to run out of battery, so I'm going to close this down in a second. The thorax, as far as the spinal manipulation is concerned, is a very common area to manipulate. It is prone to osteoporosis. The ribs are fragile, the vertebra too. You've also got a problem in the spinal canal, in that it's very small compared to the content. So if they're a bleeder, there's a tendency to bleed, and they bleed into that. The consequences are much worse than they is in the lumbar spine or cervical spine. So it's an area you need to be careful of, but it's also an area you're going to be manipulating a lot. All right. So if you've got any more questions for me, I'll plug it in if I can find a plug, but I'm going to have to do it quick. Have you? No, we good? All right, guys. Well, thanks for coming, and I will talk to you again next Sunday. All right. Take care. Have a good week.
Thank you.
Take care in Alberta. You're a mess there. You're a mess, aren't you? So be careful.